This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
I've been here for just over 6 months now, and it's been a terrific experience onboarding and getting to know all of you as an organization in terms of what UCLA is all about. And one of the things that we're all about is making sure that our patients are kept safe from harm. It's a primary responsibility that we have when we take on the duty and responsibility for the care and treatment of patients. So all of us, with virtually no exceptions, we don't come into a clinic or a facility intending to do harm, but sometimes things do happen because of systems-related issues. And I have to tell you, during my career and my journeys, my perspectives on patient safety and its impact has evolved over time. As a trauma director to eventually as a division chief for trauma, as an associate CQO, and eventually as a CMO, I started having perspectives about patient safety that were quite different than very early in my career. So I want to share with you those experiences, because some of those experiences in terms of patient safety is actually driving a lot of the behavior and a lot of the, our reputation, both as individual physicians as well as hospitals and health systems. And so I want to have a conversation about that. So just to let you know how this is going to play out, we're going to help you understand how high-profile patient safety events has essentially influenced the healthcare industry in recent years, and understand the fundamental challenges facing the healthcare industry, specifically, how the concept of value is starting to hold us all accountable for the kinds of care that we deliver, and also understand how patient safety events are becoming reputational drivers for healthcare systems and individuals. So I want to start way back and kind of give you just some observations, since this is about a journey. How many are residents here in the room? Just kind of curious. Okay, terrific. A good number of you. So when I started my internship, just to give you a little perspective of my generation and where I was at, the Dow Jones Industrial Average had just broke 3,000. It's pretty impressive. The World Wide Web that Al Gore had started was in 1991. So some of you may remember that debate. Actually, Al Gore thought he invented the World Wide Web. Gorbachev actually resigned in 1991, which was a significant event, because as you know, Reagan and Gorbachev were essentially responsible for the teardown of the wall that separated Germany at the time. The combat disc was introduced during my internship in 1992. And getting down to more patient safety issues, my year in a general surgery program was actually the first year of the rectangular program. I don't know how many of you are familiar with this. This is a unique surgical thing. So prior to that year, residency programs would accept 12 residents and graduate 3. They didn't separate preliminary versus categorical, so it was totally a competitive process, and you usually didn't know if you were graduating until really at the very end. And so our year was the first year where they decided to outlaw it, essentially the surgical RRC, and said, now the programs are rectangular. You bring in categoricals, you graduate categoricals, preliminaries go to other places. Now, of course, since this was the first year, a lot of us really didn't believe it. And I can tell you throughout the 5 years, we weren't really sure until we were sure we had the piece of paper in our hands. But we talk about generational perspectives on patient safety. There's definitely a generational perspective, because I would say, to a large extent, how the RRC was evolving at that time created separation in thought process sometimes between those that are my age and those that are older, particularly among the surgeons. And the other thing, this is more of a trivial pursuit type of question, but the State Board of Regents in New York dropped negligence charges against a specific family physician in what case in 1991? This is really a hard question. I wouldn't expect you to answer it. But essentially, there was a family doctor that was involved with a case, also with an intern and resident. And that intern and that resident, the year before, in 1990, was actually found grossly negligent in a particular case. And for those of you where you're starting to get a recollection of what that is, it has to do with Libby Zion. So among the residents, how many of you know about the Libby Zion case? Are you familiar with it? I see less hands now, which is rather interesting. So let me tell you a little bit about Libby Zion, because in terms of patient safety events, I think this is where it really all starts, because she fundamentally, changed our viewpoint on how we practice and how we train residents. So Libby Zion was essentially a 19-year-old girl. She went to Bennington College. Basically, things were fairly routine. Her father was a lawyer and a former New York Times writer. You can kind of see where this is going, right? Her mother, a former publishing executive, perfect storm. And Libby was essentially presented to the emergency department at New York Hospital because she was having flu-like symptoms. Again, nothing really out of the ordinary. And this happened back in March of 1984. So you can see in New York State how this process kind of rolls out over time. And so the plan was, again, fairly routine. We'll admit her, we'll observe her, we'll hydrate her up, monitor her vital signs, and hopefully we can get her out in short order. And a PGY1 and a PGY2 were both assigned to her case, the same PGY1 and PGY2 that I had mentioned before. And essentially, less than 8 hours after she was admitted in the emergency department, Libby was dead. Young, healthy, 19-year-old, just like that. And so what happened? Well, the residents had prescribed piperidine to control what they saw as strange jerking movements after consulting with the primary care physician. And by the way, the primary care physician never saw Libby during her hospitalization. The nurses contacted the PGY1, who prescribed physical restraints for increased agitation, and also essentially Haldol as well. I should tell you, as a resident, when I started my residency in 1991, for some reason the attendings were very squeamish about the use of Haldol. By 6:30 a.m., her temperature was known to be 107 degrees Fahrenheit, and the PGY1 was contacted, but before she could be fully assessed, she essentially developed a cardiac arrest and died. So her pre-admission medication was phenelzine for depression, and the combination of that drug and the piperidine led to serotonin syndrome, and that's why she died. That's why she had the increased agitation. That's why she had the high fever. That's why it was unrecognized until it was actually too late. And so, in 1984 was very different from today because, at that time, there was no computerized physician order entry. There was no alerts that popped up that basically told you there was a drug-drug interaction going on. There was no guidance in your orders in terms of, what the correct dosages for different kinds of medications. And so, you kind of make your orders, and there was less oversight and engagement with residents at that time than there is now. And so you can probably imagine the family reaction around this particular case. So the father basically said, and I quote, "They gave her a drug that was destined to kill her, then ignored her except to tie her down like a dog." And there was a New York Times op-ed piece. "You don't need kindergarten to know that a resident working a 36-hour shift is in no condition to make any kind of judgment call, forget about life and death." So all of a sudden, there was conversation going on that really rocked the medical community in ways that had never happened prior to that time period. There was a grand jury investigation on this. Both residents were up for murder charges. They were not indicted, but they were brought up on 38 charges of gross negligence and incompetence. The State Board of Professional Medical Conduct in New York decided that there was no evidence to support the 38 charges. Because it was a politically hot issue, the New York Board of Regents became involved. And although they didn't have the same kind of authority as a grand jury or a State Board of Medical Conduct, they decided to formally censure and reprimand the residents. There was a civil trial 11 years after the event in 1995, where essentially prescribing the wrong drug, they concluded, contributed to Libby's death, and they ordered the residents and the primary care physician to pay $375,000. And the hospital was found to really be negligent for leaving the PGY-1 alone with 40 patients at night, although this was not directly related to Libby's death. And by the way, it doesn't sound surprising to me at all that one PGY-1 would have 40 residents. When I was a medical student rotating on the surgical clerkship, there was typically 90 patients on the service and 3 interns, and they were roughly equally divided. And so it didn't seem really unusual, but that was the environment we were operating in. So there was something called the Bell Commission, and that was formed in New York. Many of you are familiar with that. And they started imposing, caps on resident hours. 80 hours per week, can't work more than 24 consecutive hours. Attendings really need to be physically present in the hospital at all times and available to supervise the residents. And eventually what happened was the ACGME, watching what was happening in New York, decided to become proactive about it because they felt that eventually they were going to be ordered to do something. And unless the medical community took control over the situation and actually, put not only some teeth around it, but some accountability for it. They felt that they could actually be able to control the hours and also provide the kind of quality education that residents deserve. And so the ACGME adopted, similar standards in 2003. So fairly recently. So there was a whole national discussion about this event, and there was general acceptance, I say general, that excessive resident work hours were not ideal. I say general because in New York at that time, surgery programs actually fought tooth and nail the Bell Commission's recommendations, which eventually became law. There was disagreement and heated debate about whether long resident hours actually impacted patient care, even though intuitively we think it could, but there wasn't any direct evidence. Controversy was really typical of a culture of blame and finger pointing, and really the whole event around Libby Zion's death really highlighted all the deficiencies and oddities about medical care and how we hold each other accountable that was displayed for everyone really to see. Now, the Bell Commission never really directly addressed the system issues that directly contributed to Libby's death, but there was a national conversation about how we train residents, how we supervise residents, how attendings even take care of their patients, and is it really okay to be in an office far away while there's a really sick patient someplace else and have a PGY-1 in July to essentially manage that patient by themselves. I certainly was in that situation as a PGY-1. So I'm sure you're saying, well, that was then, aren't we doing much better now? That's kind of old news. Things have changed. We're much better. We certainly have improved in terms of quality and safety. So what does that have to do with the price of tea in China, you might ask? So follow this line of reasoning, because this is kind of an interesting perspective of looking at this. So question. This is really a numbers game. 20,000. An interesting number. In context, who knows what it means. But 20,000 essentially is the number of patient complaints that the Joint Commission receives every year. It's an astronomical number. I was at the Joint Commission recently several months ago, and you see this relatively small office where they process all of these complaints. A typical hospital that might get 1, 2, or 3,000 complaints has a lot of difficulty keeping up with that, but the Joint Commission processes about 20,000 a year. 270 number of passengers on board one commercial jumbo jet airliner. 98,000, probably a number that's familiar with you. 98,000 is the the finding by the Institute of Medicine some years ago, where up to 98,000 patients were felt to die because of medical errors in our facilities, healthcare facilities. 98,000 is also the number of deaths each year if one commercial jet crashed every day. Third, the third leading cause of death in the United States is medical errors. It's unbelievable. If you look at the number, it turns out to be exactly that, 325,000. That number is actually behind heart disease and cancer. So have we improved? Probably not as much as we should be. So entertain me here. So 325,000 medical errors each year that in some way there's a death associated with it. Let's just assume that all 20,000 of those patients that complained to the Joint Commission, or maybe their family members, that all of them were related to a death, just for purposes of this exercise, okay? The Joint Commission also, each year receives about 5,000 sentinel events that it has to investigate that is associated with death. So assuming that there are 25,000 deaths that they're aware of, that leaves about 300,000 medical errors associated with death that are not reported. If you look at the literature, maybe 50% of those medical errors are actually not preventable at all. And then what you have is 150,000 preventable medical errors not reported, leading to patient death. So let me give you another perspective on it. So this is a plane of MH370. So it's about 4 or 5 months ago, all of you know that plane was lost mysteriously, we think, somewhere over the Indian Ocean. So it holds 229 passengers and crew. And essentially, if you were to divide that number by the 150,000 patients that we don't even know how they died, there would be about 12 flights disappearing every week. The same reason why we don't know why that plane disappeared, from a Joint Commission perspective, they don't know why 150,000 patients disappeared, because it's not reported and it's not understood. It's an interesting way of looking at it, and that's how my perspective has kind of changed over the years. So let me tell you about the Pennsylvania experience. How did they tackle this issue of not knowing what's going on, even in their own state? Because I spent about 8.5 years in Pennsylvania. So Pennsylvania passed something soon after I got there called Act 13. And so many states were in sort of a medical malpractice crisis at that time, and to a certain extent we still are. And in order to keep some controls over medical malpractice, but also increase transparency, basically what the legislators kind of negotiated with healthcare representatives in the state was they said, we're going to pass this Act 13, and we're going to put some dollars into a fund that essentially you can use as a first line of insurance if there's a medical malpractice claim. You get to dip into it without having to use some of your reserves, and thereby reducing your costs. In return, we're going to set up something called a Patient Safety Authority. And that Patient Safety Authority is going to collect information on all serious adverse events that occur in your hospital. Now, we'll collect the information, we'll de-identify it and report it out to the state to basically say, how the hospitals in Pennsylvania are doing in terms of patient safety and reducing serious adverse events. But it needs to be reported, at least to us, and we'll report it out in a de-identified way. But we do want real transparency. So here's the catch on this. So in return for all of this, all you have to do is every time there's a serious adverse event is give a letter to the patient or their family informing them that an error occurred in their care. So the reaction was often, and should the check go with that too? And how many zeros do you write with it? So this process had occurred throughout Pennsylvania. So patients or sometimes their families, where a serious adverse event occurred, we didn't just mail out the letter, but there would be a family meeting, typically with CMO and their primary provider, acknowledging that an error occurred. And then we would give them their letter, informing in writing that the error occurred, producing harm, and this is what we did to correct it. Interestingly, and it shouldn't surprise you, that actually the settlements and judgments and cases that were occurring in Pennsylvania started decreasing as a result of this. Why? Because there was open communication and transparencies. There was apologies from hospitals and physicians about errors that occurred, and people felt that despite the fact that an error was occurring, everyone was trying their best to make sure it didn't happen again. And so it was so successful from the state's point of view that they decided to also enact Act 52, and that had to do with hospital-acquired infections. So if you got a COI or central line infection, you would also get a letter informing you, if you didn't remember or know, that essentially you developed an infection while you were in the hospital. So that was one way of Pennsylvania actually getting their mind wrapped around how many adverse events do we have, and holding all of us accountable for the transparency part. And so all this conversation really has to do with the value that we're providing our patients. And are we delivering optimal care? Are we keeping patients safe? Are we good stewards over our resources? And increasingly, this conversation has been happening over a number of years, and it's been ramping up. A lot of it has to do with the patient-physician relationships that we're having that are evolving. It's much more difficult for patients to see us. We don't have as much bandwidth. We don't have enough operational efficiency to be able to have patients come into our clinics or our offices effectively. We're still a illness-oriented type of system. We're not as involved in preventative care as we need to be. Patients are becoming increasingly dissatisfied with their experiences and the complexity of care and the difficulty it is to navigate through the various providers and laboratory tests and radiology imaging to coordinate their own care. Communication is difficult, and so they're a little bit frustrated about what value they're getting from the healthcare premiums that they're spending. And couple this, too, with some of the financial challenges as well, because there's increased complexity of care. There's technology and procedures and drugs that are costing more. There's an explosion of knowledge and still increased specialization. And all of that is really driving the cost of healthcare. And it's led to an interesting financial crisis. Now, I love this slide. This slide is actually, a 2006 slide from the Congressional Budget Office. But it really is in the context of why there is such significant debate around 2010, 2011 over tax reform and healthcare reform, regardless of the party that was going to be in charge of, Congress or the presidency. But what you can see here is that the area in black is the interest that's being paid on the debt. And this next area up here in the darker gray is the amount that we're paying for Social Security. And this other lighter gray area is what we're spending on Medicare and Medicaid. And the area in white essentially is all other discretionary spending. And so what was predicted essentially is that by 2030, quite clearly, we wouldn't have enough money for discretionary spending, and it was already going to be starting to cut into Medicare and Medicaid. As a matter of fact, at that time, the Congressional Budget Office predicted that unless we get control over things like Medicare and Medicaid and our healthcare spending, it predicted total economic collapse by 2037. And they did predict that something different would have to happen around the 2010 to 2012 period of time in order to at least kick the can down in terms of the spending that's occurring. So the reasons for it are fairly straightforward. There are fewer workers supporting people that have now retired that need health care, because health care utilization increases as you get older. And so we've seen that trend. And the question is, how do you manage those resources much more effectively, knowing that the revenue stream is decreasing over time? And so what people are starting to talk about is value-based purchasing. How to transform Medicare, Medicaid, and even commercial payers, how to transform the payment system in a way that we improve population health, that we actually change from being essentially a sickness or illness-oriented industry to one that's preventative, one that improves the patient experiences, one that reduces healthcare costs, and really overall to make sure that patients are safe from harm and that they're getting optimal care in a way that really makes sense. Is it providing value? So there was, as part of that, value-based purchasing was enacted in 2011. And for those of you that are not familiar with it, the value-based purchasing program is essentially a at-risk Medicare program where 1% of the dollars that are paid are withheld. And you get that 1% back if you meet certain clinical metrics and you meet certain patient experience metrics. And hospitals have now become very familiar with this over the last couple of years. But value-based purchasing is going to increase and expand to hospice care by 2016, to rehab and LTACs also by 2016. Psychiatric hospitals, and cancer hospitals will also be affected by this in 2016. But most importantly, as you can see here, at the very end, the physicians will be pulled into value-based purchasing as well. And using a set of metrics that are yet to be fully defined, there'll be risk-based compensation for the care that's provided based on variables. Right now, value-based purchasing doesn't include patient safety measures, but it likely will include patient safety metrics at some point in time. Tentatively scheduled for 2017, we've all heard of Hospital Compare. There'll also be something called Physician Compare, so that essentially the consumer will be able to log on at a CMS site, look at a particular physician and see what their metrics are for managing a certain population. So that transparency is all within the ACA. And so there are major drivers to these costs, and they're all pretty apparent. There's an aging population, there's chronic disease, and hence the reason why we need to better manage our populations. Technology continues to expand and increase. Pharmaceuticals are expensive, but we've gotten some control over that. Outcomes is a big deal in terms of driving up costs in healthcare. And there are insurance and administrative costs that are also part of the mix in terms of driving the cost of healthcare. But by far, the most important variable in there is actually the physician practice. The physicians ultimately, to a certain extent, have a large control over the costs and how individual patients should have their dollars spent. They have a fair amount of control over the quality, or at least in some cases a leadership role in that area. And they have ultimate control over value. And that's the consensus feeling. And so how does this group define quality? So I'm sort of really interested. But I can tell you that based on my experiences and travels, even the last 6 months here at UCLA, quality is really being defined as the patients that we serve, of course, that's the primary thing. But increasingly, it's also quality is being defined by those external organizations and individuals who judge the value of the clinical services that we provide along the continuum of care. So there's increasing transparency out there in terms of metrics, and these metrics are used to basically make judgments about us. Who are our stakeholders? Well, there's the private sector. We're, I think, increasingly familiar that U.S. News and World Report, of course, does rankings with hospitals. We just recently came out ranked number 5 again. There's consumer reports. There's also Leapfrog, which gives out letter grades from A, B, C, D, and F. There are public agencies like CMS, and you can log on to Hospital Compare and get various data on UCLA and Santa Monica and Cedars as well. And in addition, there's the Joint Commission, and there's our California Department of Public Health, too, or agencies that we're all accountable to. And then, of course, there's our academic community, because we form a university healthcare consortium where other academic medical centers join in, and we provide data and benchmark ourselves against each other. And there are specialty databases, like in pediatrics, like NACRI, and there are other databases and other specialties like NSQIP and STS and ACC as well. And so there are advocacy groups out there that we have to pay attention to, like Leapfrog. There's governing bodies like our regents. There's consumers and patients. There's insurance plans. There's government, and there's employers. All of them have a vested interest in how UCLA is doing, and we're all accountable to each and every one of those entities. So let me give you as an example how others out there is defining quality, just to give you a relatively small but straightforward example. So for the residents, for those of you that are not familiar with this, the AHRQ within the government created something called the patient safety indicators. And it's a set of indicators that basically defines a series of complications. It's along surgeries, along procedures. It's also some childbirth metrics in there. And it's used to help healthcare organizations assess, monitor, and track and improve the safety within their inpatient environment. And it's used for comparative public reporting. And it helps everyone kind of identify potential opportunities for improvement. And there are about 27 different indicators out there that was created. It includes death among surgical patients with treatable serious complications, includes iatrogenic pneumothorax and post-op hemorrhage and post-op sepsis and accidental puncture and laceration and foreign body left during procedures. A lot of surgically oriented ones, but a few medical ones, and as I mentioned, obstetrical ones as well. And what's interesting is that there are 27 different indicators, just to point out some of the complexity. And AHRQ decided to use 11 of those indicators and create a composite index, what's called the PSI 90. And so CMS says, wow, those patient safety indicators are really good. We can use them in our publicly reported website called Hospital Compare. So it uses 6 of those indicators plus the PSI 90 composite index. So when you actually log on to the website, we're accountable for 12 of the 27 PSI indicators from a CMS perspective. Leapfrog looks at 6 of them. UHC looks at 5 of them. U.S. News and World Report now looks at 8 of them. And so they kind of pick and choose which indicators that they want, and except for indicators 6 and 11, there's really not a lot of overlap between them. And they each have different methodologies. So Leapfrog's methodology and how it weights those indicators is different from UHC, which is different from U.S. News and World Report. And so it's a rather complex stew in terms of how different organizations and advocacy groups and government makes judgments about us. And so no surprise, if you look at the top 10 highly ranked UHC top performers in quality and safety, only 2 of them actually made U.S. News and World Report. You can also see that in terms of Leapfrog grades, there's some variability there where in Leapfrog, they're not necessarily all A players. So we're dealing with different methodologies and complexities, and all of these different entities, UHC, Leapfrog, U.S. News and World Report, Hospital Compare, are major players out there in the public space that's holding us accountable and making us transparent in terms of patient safety, and also tracking the dollars and making us accountable in that way too. To take it one step further, Leapfrog is, although it's a private group formed with some Fortune 500 companies, they created this interesting calculator for large companies. They say, as you create your insurance network and you have your employers eligible to go to certain types of hospitals within that network, take a look at Leapfrog and see what your mix is of A, B, and C hospitals, and then punch in a few straightforward numbers, and we can tell you what the quote-unquote hidden surcharges that you pay for based on your mix of A, B, and C or lower hospitals. The better your mix, the lower your costs. If you have more C's and B's, the higher your costs. It's pretty straightforward and fairly consistent. And so even a private advocacy group like this is having ultimate influence in terms of us really looking at patient safety in a very, very serious way, using many of the metrics that AHRQ has created. So when you're faced with the challenge of what to do in an increasingly complex society when it concerns patient safety, you often ask other top performers what drives their success. And it's really interesting because I had that opportunity to have a structured interview with a number of top UHC performers and ask them a number of questions in different types of areas. And what's really interesting is that if you take one organization, for example, and maybe you do evidence-based guidelines that reduce VTE prophylaxis, okay? And they put it into their order set, their admission order set, and they find that it's wildly successful. 90% of the docs use it, they're very compliant with it, and they see their VTE rates actually drop. You put it into a different organization, and maybe only 50% of their docs are using it, and they're not making any gains. And what's the difference between those two facilities? Well, they'll all tell you that it's not the tactics that they lose, but really what it is, it's leadership and it's culture. That's really what separates the top performers from everybody else. And so for leadership, I mean, if I were to tell people here what, in terms of U.S. News and World Report, how does our leadership and our culture drive our success? I say it's pretty straightforward. We have a CEO that's very much engaged. We have chairs that are engaged in U.S. News and World Report. They're very passionate about it. And we have a culture that tends to be more decentralized, more entrepreneurial, that allows for people in their local level to create and innovate around quality and safety. That's the assets, that's the strengths that is UCLA. At the end of the day, though, all of us have to be responsible, though, for driving a much more disciplined safety culture within our organizations, because even one event is too many events. And how do you do this? There are different ways of doing this. AHRQ also has a tool called a culture of safety survey. And many hospitals use this tool to essentially assess their safety culture within their organization. There's hospital survey, there's an outpatient survey, there's home care, there's hospice. But you can essentially take the survey and distribute it throughout your entities within your health system. And what I found out was something very interesting. There's an individual named Brian Sexton from Duke University who actually introduced some questions, not everywhere, but in some selected institutions, assessing the degree of burnout and stress within departments. So some organizations have done this where they've introduced these questions into the AHRQ Culture of Safety survey and found something really, really interesting. They found out in many organizations, 1 in 5 units, or departments suffer from burnout. And some of these units are in high-profile locations. So imagine intensive care units, emergency departments. Some of these nursing units had high burnout, low stress recognition, low safety scores, and also associated with high nursing turnover rates, low employee engagement scores, low patient satisfaction scores. He has sort of some interesting recommendations too. And by the way, there are a number of things that are driving some of that dissatisfaction in areas that have burnout that are very much operationally based: nursing staffing issues, nursing assignment issues, how patients flow, teamwork and communication, as well as equipment and supply issues. And so what was essentially found out was that those areas that are suffering from burnout, and where you're finding that you're having difficulty making traction with patient safety issues and quality issues, until you solve the burnout issues, you're not going to move the needle with the quality and safety issues. It's why in one area, even within the same hospital, you can ask a nursing unit to do one thing related to quality or safety, and they'll say, just fine, it's great, we'll do it. And in another unit, which is much more stress, feels that they can't take on just one more thing, because we haven't created the operational efficiencies that makes their work and their jobs much easier. So I want you to think a little bit about leadership and culture, because I want to show this video clip here. And I think it's really important that you process this in terms of the context of accountability, leadership, culture, and the roles that we all play in keeping patients free from harm.
Hi, I'm Alicia Cole. I'm an actress. I live in Los Angeles, California, and I've been an actress, been in the Screen Actors Guild for 19 years. In 2006, I found out that I had fibroids. So I thought, okay, well, if I get these fibroids taken out in August, I'll be healed, I'll be ready for the start of the television season. I was supposed to be in the hospital 2 days in and out. I had the surgery, but I never got better. It just spiraled from there. My breathing started becoming very labored, and my heart rate just went crazy. My abdomen was flaming red, and it was hard like cement, and it was on fire. My mother saw a black dot, like you took a Sharpie marker and just gently went like that. It took the doctor about an hour and a half to get back to the hospital. And he said, oh my, okay, now we need to be concerned. The black dot was like the size of a quarter. It looked like my skin had melted. He looks at my mother and he says, Mrs. Cole, are you squeamish? And my mother said, no. And he said, good, because I need you. I was terrified to ask my mother to assist him and not wait and take me back to the operating room in a sterile, clean environment, to take a tray with gauze and put it in the windowsill overnight, and then take that same tray, lay it across my legs, and start pulling gauze out of an already open box. And they basically use their hands to pull open my incision. I've never felt that kind of pain, ever in my life, ever. The infection was spreading about an inch every hour on the surface, so even more underneath. So the infectious disease specialist should have been there that night, but she didn't come until the next afternoon. No one really paid attention to the signs and symptoms that I had. In that hospital, starting from the top down, there was a lack of consideration for the patient. It wasn't until after that, a few days, that the doctors verbally told my parents what I had. Sepsis, Pseudomonas, VRE, MRSA, and necrotizing fasciitis, flesh-eating disease. It was an indication of a total system breakdown. I was in a prominent, beautiful facility. I did my homework. I did what an engaged patient is supposed to do. I was proactive. But my 2-day hospital stay for routine fibroid surgery went from 2 days to 2 months in the hospital, a month in ICU, 9 blood transfusions, 6 additional surgeries, almost having my left leg amputated. I had a year and about 2 months of twice-a-day home health care nurses. I had an open abdomen for 3 years that would drain. Physical therapy off and on for at least 4 years. Doctor's appointments every week for the last 7 years. And over $2 million in medical bills. I used to have a lot of faith in the system. When I see what's happening in healthcare and people who it's just a job and coming to take care of a woman who's missing her abdomen, and I don't bother to read her chart before I get there. Or I don't bother to wash my hands. That kind of thing hits me at my core because it's not how I was raised or who I am. We believe in honor and loyalty and truth and standing for something, no matter what the cost. My life is completely different. It's, I was a cheerleader, volleyball, basketball, softball, ran track, bowling, you name it. So that's real hard. I had the most amazing support system going through this. It's what saved me, literally what saved me. There are so many patients who are by themselves, and that's why it's so important to me to speak out, to advocate, to give back. And I'm very, very proud to have been a part of the 2 laws for public reporting of hospital-acquired infection rates in the state of California. Our hospitals are scary places. Our healthcare system is broken, but there is hope. And that hope is patience, patient engagement, patient involvement. Albert Einstein says, you cannot fix a problem with the same mindset that created it. Patients bring a fresh perspective. We are the secret weapon, the magic bullet. Patience will change healthcare.
So nobody tells it better than actually the patient. And what really happened here? Is it scrubbing technique? Is it the use of double gloves? Is it appropriate hand washing? How we take care of wounds and dressings? At the end of the day, really, it's about personal accountability. All of us are leaders in quality and safety. All of us drive our culture. And so all of us play an important role in keeping our patients safe from harm. It's a privilege to actually be able to lay hands on a patient, to use our hands as a diagnostic tool, to heal with it, to comfort, and to provide a source of trust through your hands. There's also a potential to do harm with that same instrument. And it's amazing that there's actually still physicians out there who don't believe that hand washing is actually important, despite the fact that there's literature out there that basically shows time and time again how hand washing really helps reduce mental layer-associated pneumonias, reduce mortality rates, et cetera, et cetera. So I talked to you a little bit about, at the beginning, what quality is. And there's been a lot of emphasis on the external environment defining for us what patient safety actually is and how they're using it to make judgments about us. But at the end of the day, it's the patient's experience that really is quality. Patient experience is the overriding factor here, because patients don't expect to have a healthcare acquired condition. They don't expect to have an adverse drug reaction like Libizion. They don't expect to have a catheter-related urinary tract infection or a central line infection. They don't expect to fall and get injured in a hospital or have obstetrical adverse events. They don't expect their wounds to be infected or to get a blood clot in their legs that travels to their lungs. And they don't expect to get a ventilator-associated pneumonia. They expect to get well. They expect to be discharged in a reasonable period of time, and they have an expectation that soon after they leave our hands, that they'll have an improved quality of life. And so I'll take that with you, because there's no better place to end than with the patient voice. We want to be a leader and help those patients too to be able to enjoy a much better quality of life through UCLA.